I'm Dr. Sarah Mitchell, and I spent 14 years working as an emergency room physician at Los Angeles County plus USC Medical Center. Or at least I did, until I submitted my resignation 3 months ago. During my career in one of the busiest trauma centers in the country, I've seen everything you could imagine. Gang violence, mass casualty events, overdoses, car accidents, and every type of human suffering that walks through those automatic doors at 3 a.m. But what I'm about to tell you about is the one case that made me question not just medicine, but the very nature of reality itself. LA County plus USC is a level 1 trauma center serving downtown Los Angeles and surrounding areas. We handle over 180,000 patients per year in our emergency department alone. It's the kind of place where you learn to expect the unexpected, where medical residents are forged in fire, and where veteran nurses have seen things that would make most people quit medicine entirely. I thought I had seen it all. The night of October 7th, 2023, started like any other Saturday in the ER. I arrived for my shift at 7 p.m., the sun just beginning to set over the downtown skyline, casting long shadows through the ambulance bay. My attending physician that night was Dr. Marcus Chen, a 30-year veteran who had literally written chapters in emergency medicine textbooks. Our nursing staff included Rita Gonzalez, who had been working the night shift for almost 20 years, and 2 younger nurses, Kevin Park and Amanda Sterling. By midnight, we had already treated a stabbing victim, 3 drug overdoses, a woman in active labor who didn't make it to the maternity ward in time, and the usual parade of chest pains, broken bones, and desperate people with nowhere else to go. It was a typical Saturday night in downtown LA. At 1:47 a.m., everything changed. The call came in from Fire Station 9. Major vehicle collision on the 110 freeway. Multiple casualties. ETA 6 minutes. I remember looking at the clock on the wall, the second hand sweeping past the 12, because what happened next made me obsessed with tracking time down to the second. The first ambulance arrived at 1:53 a.m. The paramedics wheeled in a man I would later learn was named John Doe. They literally had no identification on him. He appeared to be in his mid-40s, wearing expensive but torn clothing, with severe head trauma and multiple lacerations. His eyes were closed, and he wasn't responsive to painful stimuli. But here's what made me notice him immediately. Despite the severity of his injuries, his vital signs were stable. Too stable. Heart rate of 72, blood pressure of 120/80, oxygen saturation at 98%. For someone who had just been in a major collision severe enough to cause significant head trauma, these numbers made no sense. Vitals don't match the mechanism of injury, I told Marcus as we began our primary survey. He should be tachycardic, probably hypotensive from blood loss. Marcus nodded, checking the patient's pupils with his penlight. Equal and reactive. No signs of increased intracranial pressure. But look at this laceration pattern. The cuts on the patient's arms and chest were strange. They were too uniform, too precisely spaced, almost as if they had been made deliberately, rather than sustained in a chaotic accident. But the paramedics had pulled him from a crushed vehicle, so the trauma had to be real. We ordered the standard workup: CT scan of the head and chest, full trauma panel, toxicology screen. While we waited for imaging, I performed a more detailed neurological exam. The patient remained unresponsive, but his reflexes were hyperactive, his muscle tone was perfect, and there was something about the way his closed eyes moved beneath the lids that suggested he was aware of his surroundings. At 2:14 a.m., I remember the exact time because I was documenting the initial assessment in his chart. The patient's eyes opened. They weren't the confused, disoriented eyes of someone emerging from unconsciousness. They were sharp, focused, and they fixed on me with an intensity that made me take a step back. His eyes were an unusual shade of amber, almost golden, in the harsh fluorescent lighting of the trauma bay. "Dr. Mitchell?" he said, his voice clear and steady, despite never having been introduced to me. "The woman in bed 7 will code at 3:33 a.m. You won't save her." The room went silent. Rita, who had been adjusting his IV line, froze. Kevin, who was taking his blood pressure, looked at me with wide eyes. Marcus stepped closer to the bedside. "How do you know my name?" I asked, keeping my voice calm and professional. "And what makes you think someone is going to code?" The patient, I still didn't know his name, smiled slightly. It wasn't a warm smile. It was the smile of someone who knew a secret and was deciding whether to share it. "The woman in bed 7 has a pulmonary embolism, a large one, right main pulmonary artery. It will dislodge at 3:33 a.m. You'll try to give her thrombolytics, but the bleeding from her earlier surgery will be too severe. She'll die at 3:47 a.m. I felt a chill run down my spine. Bed 7 was occupied by Patricia Ramirez, a 58-year-old woman who had come in 3 hours earlier with shortness of breath following a routine knee replacement surgery 2 days ago. We had suspected a possible pulmonary embolism and had ordered a CT angiogram, but the results weren't back yet. "Who are you?" Marcus asked, his usual calm demeanor cracking slightly. "How do you know about our patients?" The patient closed his eyes again, as if the brief conversation had exhausted him. "My name doesn't matter, but you should check on the woman in bed 7, and when she codes, you should know that the man in bed 14 will arrest at 4:17 a.m. Ventricular fibrillation. He won't respond to defibrillation because he's been taking unprescribed beta blockers that aren't in his medical history." Then he went completely still, his vital signs remaining eerily stable, his breathing slow and regular. It was as if he had simply decided to return to unconsciousness. "What the hell was that?" Kevin whispered, his face pale. I looked at Marcus, who was staring at the patient with an expression I had never seen on his face before, fear mixed with scientific curiosity. "We need to check on Mrs. Ramirez," I said, already moving toward the door. "Rita, stay with this patient, monitor him closely, and call me immediately if his status changes." Bed 7 was in the main ER bay, separated from other patients only by thin curtains. Patricia Ramirez was sitting up in bed, an oxygen mask on her face, reading something on her phone. She looked uncomfortable, but stable. "Mrs. Ramirez, how are you feeling?" I asked, checking her vital signs on the monitor. Heart rate 95, blood pressure 140/88, oxygen saturation 91% on 4 liters of oxygen. Concerning, but not critical. "Still having trouble breathing, doctor," she said, her voice muffled by the oxygen mask. "Is it normal to feel this short of breath after knee surgery?" "We're waiting on some test results," I told her, trying to keep my voice reassuring while my mind raced. "I'm going to order some additional monitoring, just to be safe." I stepped away from her bedside and pulled up her chart on the computer. The CT angiogram results had just come in. I felt my stomach drop as I read the radiologist's interpretation. Large thrombus in right main pulmonary artery with evidence of right heart strain. The patient in Trauma Bay 1 had been right. Patricia Ramirez had a massive pulmonary embolism. I immediately paged the pulmonology team and ordered a heparin drip to prevent the clot from getting larger. But the patient's words echoed in my mind. "You'll try to give her thrombolytics, but the bleeding from her earlier surgery will be too severe." Marcus found me at the computer station. The CT results? Massive PE, right main pulmonary artery, just like he said. I pulled up the imaging on the screen, showing him the dark filling defect where the blood clot blocked the major vessel carrying blood from the heart to the lungs. "This is a coincidence," Marcus said, but his voice lacked conviction. He probably overheard us discussing her case.
Or maybe he's a healthcare worker himself who knows how to interpret symptoms. He knew my name, Marcus. I've never seen this man before in my life, and he specified the exact time she would code. We stood in silence for a moment, watching the clock on the wall. It read 2:31 a.m. "We have an hour," I said. "Let's make sure we're ready." I spent the next 60 minutes preparing for what I hoped wouldn't happen. I reviewed the protocols for treating massive pulmonary embolisms, made sure we had thrombolytic medications drawn up and ready, and briefed the nursing staff on what to watch for. Patricia Ramirez remained stable but uncomfortable, her oxygen saturation hovering in the low 90s despite supplemental oxygen. At 3:15 a.m., I returned to Trauma Bay 1 to check on our mysterious patient. He was exactly as we had left him, lying still with his eyes closed, his vital signs unchanged. Rita was sitting beside his bed, and she looked unsettled. "Has he said anything else?" I asked. "No, but Dr. Mitchell, there's something wrong with his telemetry." She pointed to the cardiac monitor. "Look at his heart rhythm." I studied the screen. The patient's heart rate was exactly 72 beats per minute, and had been since his arrival. But the pattern of the QRS complexes was too regular, too perfect. Normal sinus rhythm has slight variations in timing, subtle irregularities that reflect the natural variability of the autonomic nervous system.
This patient's heart rhythm looked like it had been generated by a computer simulation. "That's not possible," I muttered, checking the leads to make sure they were properly attached. They were. At 3:30 a.m., I was back at bed 7, standing beside Patricia Ramirez with a sense of dread I couldn't shake. Marcus was with me, along with respiratory therapy and an additional nurse. We watched the clock, 3:31 a.m. Patricia was talking to her daughter on the phone, laughing about something. 3:32 a.m. She coughed, adjusted her oxygen mask, and smiled at me. "I'm actually feeling a bit better, doctor." 3:33 a.m. Patricia gasped. Her face went pale. The monitor alarm screamed as her oxygen saturation plummeted from 91 to 62 in seconds. Her eyes went wide with terror. "She's coding!" Marcus shouted. I won't go into all the medical details of what happened next, but I'll tell you this. We did exactly what the patient predicted. We administered thrombolytics to try to break up the clot. For a brief moment, it seemed to work. Patricia's oxygen levels improved, her color returned. Then the bleeding started. From her recent surgical site, from her IV sites, from everywhere. The thrombolytics had dissolved not just the clot in her lung, but had triggered catastrophic bleeding throughout her body. We couldn't stop it. We tried everything: transfusions, reversal agents, surgical intervention. Patricia Ramirez died at 3:47 a.m., exactly as predicted. I stood at her bedside, my hands covered in her blood, staring at the flat line on the monitor, and I felt something inside me break. 14 years of medicine had taught me that death was inevitable, that we couldn't save everyone. But this was different. This woman's death had been predicted, down to the minute, by a patient who shouldn't have known anything about her. "Dr. Mitchell," it was Kevin, his voice tight with anxiety. "You need to come to bed 14. The patient there, James Morrison, the chest pain admission from earlier, he's starting to have rhythm problems." I looked at the clock. 3:52 a.m. Bed 14. The man, our mysterious patient, said would arrest at 4:17 a.m. with ventricular fibrillation that wouldn't respond to defibrillation because of undisclosed beta blocker use. I ran. James Morrison was a 49-year-old construction worker who had come in at 11 p.m. with chest pain. His initial EKG had shown some non-specific changes, but his troponin levels were normal, and we had been planning to admit him for observation. Now, his monitor showed frequent premature ventricular contractions. "Mr. Morrison," I said, trying to keep my voice calm, "do you take any medications that aren't on your medical list? Anything you might have gotten from a friend or bought online?" He looked confused and scared. "Just my blood pressure medication." "Why?"
Anything else? Any supplements? Anything for athletic performance? Well, he hesitated. My buddy gave me some pills. He said they would help with my workouts. He said they were legal, just herbal supplements. Do you know what they were called? Propranolol? Something like that. But he said they weren't prescription drugs. My blood went cold. Propranolol was a beta blocker, a powerful one. And if he had been taking it without medical supervision, he could have built up toxic levels in his system. How much have you been taking? I don't know, maybe 3 or 4 pills a day for the past month? I immediately ordered a beta blocker level and started preparing for what I now believed was inevitable. I explained to the cardiology resident, who had come down to evaluate Mr. Morrison, that we needed to be ready for ventricular arrhythmia that might not respond to standard treatment. At 4:10 a.m., I returned briefly to Trauma Bay 1. The mysterious patient's eyes were open again, and he was looking directly at me, as if he had been waiting. You couldn't save her, he said. It wasn't a question. How did you know? I demanded. How did you know the exact time, the exact mechanism? I didn't just know about her, Dr. Mitchell. At 4:17 a.m., James Morrison will go into ventricular fibrillation. You'll shock him 4 times. It won't work. At 4:32 a.m., you'll try an experimental calcium channel blocker protocol. It will work, but he'll have permanent neurological damage from the prolonged arrest. Tell me how you know this. And at 5:09 a.m., something else will happen. Something that will make you question everything you think you understand about time, about consciousness, about the nature of reality itself. Before I could respond, the monitor alarms from bed 14 began screaming. I ran back to find James Morrison in full ventricular fibrillation, his heart quivering uselessly instead of pumping blood. We started CPR immediately. Marcus charged the defibrillator. Clear! The first shock. Morrison's body convulsed. The rhythm check showed continued ventricular fibrillation. Clear! Second shock. No change. Clear! Third shock. Still nothing. I looked at the clock. 4:19 a.m. We had shocked him 3 times, just as predicted. I made a decision that went against every protocol I had ever learned. Stop. We're not shocking him again. Start an epinephrine drip and get me diltiazem. 25 milligrams IV push. The cardiology resident stared at me. Dr. Mitchell, that's not in the ACLS protocol for... Do it now! We continued CPR while I administered the calcium channel blocker, a medication normally used for different types of arrhythmias. It was a gamble, a deviation from standard care that could cost me my license. At 4:34 a.m., 2 minutes after the patient had predicted, James Morrison's heart rhythm converted to normal sinus rhythm. He had a pulse. He was alive. But when I checked his neurological status, I felt sick. His pupils were sluggish. His response to painful stimuli was minimal. The prolonged period without adequate circulation had damaged his brain, exactly as predicted. I walked back to Trauma Bay 1 in a daze, my scrubs soaked with sweat, my hands shaking. The mysterious patient was sitting up now, no longer pretending to be unconscious. His vital signs remained eerily perfect. Who are you? I asked, my voice barely above a whisper. What are you? He looked at me with those strange amber eyes. I'm just a man who was in a car accident, Dr. Mitchell. Or, at least, that's what the paramedics will put in their report. But the truth is more complicated. Tell me the truth then. If you can predict the future, if you can see what's going to happen, tell me the truth. The truth is that time isn't what you think it is. It's not a river flowing in one direction. It's more like an ocean, and some of us can see the currents, the patterns, the waves before they crest. I don't predict the future, Doctor. I remember it. That's impossible, is it? You've seen impossible things tonight. A woman dying at the exact moment I said she would. A man's heart responding to a treatment I told you would work. When will you accept that your understanding of reality is incomplete? I pulled up a chair and sat down heavily. My shift didn't end until 7 a.m., but I felt like I had already worked 3 shifts. What happens at 5:09 a.m.? The patient closed his eyes, and for the first time since he had arrived, I saw something that looked like pain cross his face. That's when you'll understand why I can do what I do, and why I wish I couldn't. I waited. The ER continued its chaotic rhythm around us. New patients arriving, doctors shouting orders, monitors beeping. But in Trauma Bay 1, there was an odd pocket of stillness, as if we existed slightly outside the normal flow of time. At 5:03 a.m., the patient opened his eyes again. You should step outside the trauma bay, Dr. Mitchell. Stand by the door, where you can see me, but not too close. Why? Because in 6 minutes, an ambulance will arrive with a 15-year-old girl. Motorcycle accident. Massive internal bleeding. She'll die in surgery at 7:22 a.m. Her name is Emma Collins, and she's my daughter. I felt like I had been punched in the stomach. Your daughter? I've lived this night 47 times, Dr. Mitchell. 47 times I've woken up in that ambulance after my own accident. 47 times I've been brought to this ER. 47 times I've tried to save my daughter's life by changing what happens, by warning the doctors, by altering the treatment. And 47 times she's died anyway. Time is elastic, but it always snaps back to the same shape. This is insane. You expect me to believe you're trapped in some kind of time loop? I don't expect you to believe anything, but in 3 minutes you'll hear the sirens. In 4 minutes, you'll see a helmet being cut off a teenage girl with red hair and freckles across her nose. In 5 minutes, you'll see she's wearing a necklace with a dragonfly pendant that her mother gave her before she died of cancer 6 years ago. And then you'll know I'm telling the truth. I should have called psychiatry. I should have ordered a full neuro workup and assumed this man was having delusions brought on by his head trauma. But something in his voice, in his eyes, made me stand up and walk to the doorway of the trauma bay. At 5:06 a.m., I heard the sirens. At 5:08 a.m., I saw the ambulance pull into the bay. At 5:09 a.m., the paramedics rushed through the doors with a teenage girl on a stretcher, her red hair matted with blood, a helmet being cut away to reveal freckles across her nose, and hanging around her neck was a silver necklace with a dragonfly pendant.
The trauma team rushed past me, wheeling Emma toward the operating room. I heard her father screaming from Trauma Bay 1, his voice raw with desperation. Security had to restrain him as he tried to tear out his IV lines, tried to follow his daughter. His words echoed through the emergency department. "Please, listen to me. The liver laceration is on the posterior surface. You won't see it on the first look. There's a mesenteric tear at the jejunal junction. You have to check the splenic artery. It's been partially transected." The trauma surgeons ignored him. They had their protocols, their systematic approach. They didn't have time to listen to a delirious family member, no matter how specific his anatomical knowledge seemed. I stood frozen in the hallway, watching the operating room doors swing shut. The dragonfly pendant, the red hair, the freckles. Every detail he had predicted, down to a piece of jewelry that should have been impossible to know about. Marcus found me standing there at 5:47 a.m. "Sarah, you need to see this." He pulled me back to Trauma Bay 1, where security had finally managed to sedate the patient. But before the medication had taken full effect, he had managed to scrawl something on the bedsheet with a pen he'd grabbed from Rita's pocket. The handwriting was shaky, but legible. Loop 47. "Tell Emma I love her. Tell her I tried." "What does that mean?" Marcus asked. I couldn't answer. My throat had closed up, because I understood. This was the 47th time he had lived through this night.
47 times watching his daughter die. 47 times trying to change the outcome. At 7:22 a.m., exactly as predicted, Emma Collins was declared dead in operating room 3. The surgeons found exactly what the patient had described: a posterior liver laceration they had missed on initial inspection, a mesenteric tear at the jejunal junction, a partially transected splenic artery. They had followed the correct protocols, done everything by the book, but the injuries were too severe, the bleeding too extensive. When I returned to Trauma Bay 1, the bed was empty. The patient had vanished while everyone's attention was focused on his daughter's code. Security footage showed him simply standing up, walking through the ambulance bay doors, and disappearing into the pre-dawn darkness. His CT scans, when we reviewed them later, showed no evidence of the head trauma we had documented. His labs were perfect. It was as if his injuries had been a disguise, a way to gain entry to the hospital on this specific night. The only evidence he had ever been there was the message on the bedsheet and the impossibly accurate predictions documented in 3 patient charts. I submitted my resignation 3 weeks later. I couldn't continue practicing emergency medicine after witnessing something that challenged every fundamental principle of reality I thought I understood. How do you treat patients when you've seen proof that time might be a loop, that some people might remember the future, that love might drive a man to repeat the worst night of his life dozens of times, hoping against hope that he can change it? Marcus tried to convince me to stay. Sarah, what you experienced, it was trauma, stress, coincidence. Don't throw away your career over one impossible night. But it wasn't just one night, because 2 months after I left, Marcus called me. His voice was shaking. Sarah, he came back. Same patient, same injuries, same predictions. But this time it was October 7th again. Not October 7th of this year, October 7th, 2023. The same date. He told me it was loop 48. The ER staff who worked that night, none of them remember him from before except me. It's like time reset for everyone but him, and me, and now you. I moved to a small town in Oregon and opened a family practice. I treat ordinary illnesses and deliver babies, and try not to think about that night. But sometimes, when I can't sleep, I wonder if somewhere a man with amber eyes is still trapped in October 7th, 2023, still trying to save his daughter, still believing that if he just finds the right words, the right moment, the right intervention, he can break the loop. I hope he succeeds. I hope that somewhere, in some iteration, Emma Collins lives. I hope that time, cruel as it is, eventually allows love to triumph. But I don't know. And that uncertainty is something I'll carry for the rest of my life.